Hello, my name is Jeremy Rees and I'm a consultant neurologist with an interest in neuro-oncology. I'm going to talk about some common neuro-oncological presentations which you may come across in the emergency department. For those of you who are unsure, neuro-oncology is an emerging field within neurology which covers the management of primary and secondary tumours of the nervous system, neurological complications of cancer and cancer treatments, and also paraneoplastic neurological syndromes. Thinking about primary brain tumours first, these are increasingly common, particularly in the elderly, and are responsible for more years of life lost than virtually any other cancer. They're the commonest cause of cancer-related death in the under 45s, the commonest solid tumour in children, and they have devastating effects on both the individual and the family. The WHO have recognised over 150 histological subtypes, but you'll be relieved to know that these can be subdivided into 7 distinct categories, of which 6 are primary brain tumours and the 7th are brain metastases. The most common primary brain tumours are gliomas. These are intrinsic tumours which can either be low-grade with a slow-growing tumour with a tendency to malignant transformation after a number of years, or high-grade or malignant tumours which are fast-growing. You can have tumours arising from the meninges called meningiomas, and although these are generally benign tumours, they can cause serious neurological dysfunction, particularly when they're in very difficult locations to access, such as the base of skull. The next common type of tumour is a vestibular schwannoma, which is a benign tumour growing on the 8th cranial nerve, causing progressive sensorineural hearing loss and tinnitus. Pituitary tumours can present either with visual field defects, such as bitemporal hemianopia, or endocrine hyperfunction or hypofunction. CNS lymphomas are common tumours in the elderly, used to be seen only in immunocompromised patients, such as AIDS patients, but are now more commonly seen in the immunocompetent population. Then there are some tumours affecting the pineal region, the tectal plate, and the cerebellum. And as a general rule, adults have supratentorial tumours, children have infratentorial tumours. Now, as you would expect, there are multiple clinical presentations, the most common of which is raised intracranial pressure. This is a syndrome of headache, double vision, papilledema, false localizing signs such as sixth nerve palsy, alteration in mental state, decreased level of consciousness. And I want to emphasize that patients presenting with headache alone without any other neurological symptoms or signs is very unlikely to have a brain tumor. Seizures are caused by cortically based tumors. Almost all low-grade gliomas present with seizures, and the seizure type will depend on where the tumour is. So, for example, a medial temporal tumour will produce temporal lobe epilepsy. Patients often present initially with a generalized tonic-clonic seizure, but there may be a history of focal seizures with or without impaired awareness. Focal deficits are also a common presenting feature of brain tumours. Sometimes they can present quite acutely and are a cause of a stroke mimic, but more often than not, they are slowly or rapidly progressive depending on the underlying biology of the tumour, and they can cause a number of different focal deficits such as aphasia, hemianopia, and hemiparesis. Mental changes encompass both cognitive difficulties, either focal or generalized cognitive dysfunction, or personality change. Patients, for example, can become quite apathetic and abulic if they have a frontal lobe tumour, such as an orbital frontal meningioma or a bifrontal glioblastoma. And finally, with increased access to imaging for all types of problems, many patients are being diagnosed with incidental tumours, particularly meningiomas. Now, the first-line management of a brain tumour producing symptoms bringing a patient into casualty is dexamethasone. This is a corticosteroid which is almost 10 times more potent than prednisolone, and as such should be used in the smallest possible dose. And I've given some indication of the typical dosages that you would use for the different neurological scenarios. I'd want to draw your attention to the possibility of CNS lymphoma. If you see a patient who has a brain tumour and the tumours are homogeneously enhancing, often in a periventricular location, or over the splenium of the corpus callosum, think of a CNS lymphoma, and if you can, withhold DEX. Discuss with the neurosurgeons whether it's safe to withhold DEX, because DEX has lymphocytic properties and can effectively get rid of the tumour even before the tumour is biopsied only a few days later. So once you have a suspicion of a brain tumour from a CT scan, every patient should have an MRI scan of the brain with gadolinium, and this will tell you about the likely grade of the tumour, so that high-grade tumours, for example, are enhancing, low-grade tumours are usually not enhancing. It will tell you a little bit about the presence of vasogenic edema and the relationship to vital structures, and of course the anatomical location of the tumour and relationship to functional boundaries. And once you've got that, you really want to refer on to neurosurgery. Occasionally, the neurosurgeons may ask you for a CT scan of the thorax, abdomen, and pelvis, particularly if there are multiple tumours suspicious of brain metastases. But if the CT or MRI shows a really clear-cut primary brain tumour, this is usually unnecessary. So now moving on to brain and spinal cord metastases, metastatic disease in the central nervous system can go most commonly to the brain, which is usually intraparenchymal, the spinal cord, which is usually intradural but extramedullary, in other words, in the epidural space, and tumours usually come through hematogenous spread and destroy the vertebral bodies first, causing the classical triad of increasingly severe back pain, weak and numb legs, and urinary sphincter disturbance. Now, more and more often we are seeing patients with leptomeningeal metastases, previously known as carcinomatous meningitis, particularly as systemic disease comes under better control, and the CNS, if you like, is a sanctuary where a lot of the systemic drugs don't actually penetrate. As you would expect, there are a number of different clinical presentations depending on the location of the tumour, so that brain metastases will often present in a similar way to primary brain tumours. Spinal cord metastases, as I said, usually present with back pain with or without neurological dysfunction, and leptomeningeal metastases can present either with multiple cranial nerve palsies, multiple radiculopathies, or symptoms of raised intracranial pressure due to communicating hydrocephalus, as the tumour cells block up the arachnoid granulations and interfere with CSF absorption, so you develop communicating hydrocephalus. As with primary brain tumours, the imaging of choice is an MRI scan with gadolinium, and in the context of a spinal cord compression, where you have a suspicion of a level, for example, in the mid-thoracic region, it's still mandatory to do a whole spine MRI to identify simultaneous metastases both both above and below the symptomatic metastases, because clearly this will influence treatment decisions. In the setting where you suspect leptomeningeal metastases, but the MRI scan is either clear or it's equivocal, then the patient needs to have a lumbar puncture, and ideally up to 3 lumbar punctures, taking a large volume, that's at least 10 mils of CSF, and sending it rapidly off to the laboratory for CSF cytology before the cells have a chance to autolyse. And the CSF will show up atypical or malignant cells in about 90% of cases if you take up to 3 CSF samples. The initial treatment of metastatic disease is similar to primary brain tumours. Again, we use dexamethasone. In the context of metastatic spinal cord compression, dexamethasone at high dosages, for example 16 or even 24 milligrams, is very effective for early pain relief. Now, unlike the situation with primary brain tumours, obviously metastases in the nervous system are part of an underlying primary cancer, and therefore it's important to get a sense of staging of the disease, whether the systemic disease is controlled, whether there are other lines of chemotherapy. So even if there is progressive disease or widespread metastatic disease, how likely is it that you can control this with other lines of treatment? And you also want to get a sense of how fit the patient is. We call that the performance status, and that will depend on the effect of the cancer in general, other comorbidities, and of course the neurological deficits. And finally, a sense of the oncological prognosis, which will determine the aggressiveness with which you're going to intervene. And with all that information, you can then make the appropriate referral either to acute oncology or to neurosurgery. As a general rule for brain metastases, neurosurgeons will operate on large symptomatic metastases, particularly if they're in the posterior fossa, or solitary spinal cord compression, particularly if there's spinal instability. But the definitive treatment, if it's not surgical, will be with radiotherapy in most cases, either localized field radiotherapy or, in the case of brain metastases, to stereotactic radiosurgery. Now, finally, paraneoplastic syndromes are much less common than metastatic disease. They are an example of a remote effect of cancer, so they're not due to direct invasion by tumor cells into the nervous system or due to metastatic spread. There are multiple different types of paraneoplastic neurological disorders. There's actually 7 classical paraneoplastic neurological syndromes, which can affect any part of the nervous system, from the brain through to the brainstem, the spinal cord, the neuromuscular junction, and even muscle. And sometimes you can get multifocal disease or unifocal disease, for example, isolated paraneoplastic cerebellar degeneration. Now, a number of cancers can be associated with paraneoplastic neurological syndromes, including Hodgkin's disease, including breast and ovarian cancer, but far and away the most common is small cell lung cancer. And I recently had a patient who had a rapidly progressive motor neuropathy, which looked a little bit like a Guillain-Barré syndrome type picture. And we found a large prostate cancer, which had 2 distinct histological components, one the more typical adenocarcinoma, but he also had a small cell component, suggesting that there is some clear onconeural homogeneity or mimicry between small cells with the neuroendocrine derivation and neuronal cells. Now, we believe that paraneoplastic neurological syndromes are immune-mediated due to the presentation of tumor antigens triggering an immune-based attack. Now, depending on whether the antigens are intracellular or on the surface of the membrane, of the tumor membrane, of the neuronal membrane, will determine whether we're dealing with a neuronal dysfunction, which is potentially more treatable than neuronal cell death. Antineuronal antibodies can be detected in the serum and are pretty much diagnostic for paraneoplastic neurological syndromes. For example, anti-HU antibodies or anti-YO antibodies. They are not always that sensitive, but they are highly specific. And important to realize that almost all antineuronal antibodies associated with paraneoplastic disease affecting the central nervous system are not pathogenic, and therefore removal of these antibodies does not improve the underlying neurological problem. However, where the antibodies are directed against membrane antigens such as ion channels, for example the voltage-gated potassium channel in Lambert-Eaton myasthenic syndrome, then removal of these antibodies will actually improve the patient's condition. So for most paraneoplastic syndromes, the best thing you can do is to try and identify an underlying tumor and treat the tumor on its own merits, and then add in immunomodulation, particularly if there is neuromuscular junction disease. So I'm now going to consider 3 cases, fairly typical cases that you might come across. The first is a 75-year-old gentleman who was previously fit and well, no medical history until about 3 months ago, when his family noticed that he was going off the boil cognitively. He had some slight memory problems and confusion, and they thought that he was developing Alzheimer's. About 2 weeks prior to admission, he became more unsteady on his feet and incontinent of urine, and he fell in the street and was brought in by ambulance. When he was seen, he was confused with an AMTS score of 6 out of 10. He was obviously unsteady on his feet, but there were no lateralizing signs and no papilledema. He had a CT scan done in the casualty department and then an MRI scan. And for those of you not familiar, on the left here is a axial T2 weighted image, and on the right is a gadolinium enhanced axial T1 weighted scan. Now you'll see that both frontal lobes are affected. It's heterogeneous signal change with surrounding vasogenic edema and infiltration and thickening of the corpus callosum. And when you give gadolinium, the tumours enhance irregularly with rim enhancement. This is, anybody? This is a typical butterfly glioma or glioblastoma. The next patient is a 78-year-old gentleman who had a history of MS but no relapses for 30 years and had been pretty well until 3 months ago when he developed increasingly severe back pain which radiated around the side, and then more recently some difficulties walking and some urinary disturbance with hesitancy and occasional incontinence. He presented to casualty with increasingly severe back pain which was keeping him awake at night, and it was obvious when you saw him that every movement induced more pain. On examination of his legs, although he could walk, he had some proximal weakness. He was stiff with signs of an upper motor neuron lesion, in other words, brisk reflexes, extensor plantars, in other words, a spastic paraparesis. He had a sensory level to pinprick at T8, and examination of his abdomen revealed a large, palpable bladder which drained 1400 ml of clear urine. So the diagnosis here was a spinal cord compression due to a solitary destructive MET at T8, and this was due to prostate cancer. And the final case is a little bit more unusual. A 72-year-old man, lifelong smoker with COPD, who noticed about 3 months ago intermittent double vision and then some difficulty swallowing, particularly for liquids, which he thought was due to a dry mouth. He then became more difficult. He found it more difficult to climb stairs, which he thought initially was due to breathlessness, but his legs gradually became weaker, and after 100 yards he had to stop walking altogether. He was brought in after a fall in the street, and on further questioning he admitted to a weight loss of about 1 stone in the last 2 months and a non-productive cough, which wasn't particularly unusual for him. On examination he had signs of a mild extraocular muscle palsy. He had proximal fatigable muscle weakness in both upper and lower limbs, but importantly the reflexes were present and sensation was normal. And so the diagnosis here, have a think about it. Given his long-standing history of smoking and COPD, he had a chest x-ray, and hopefully you will have noticed that he has a large right apical tumour which turned out to be a small cell lung cancer. So this is Lambert-Eaton. So to finish, I would recommend, if you want to read more about this, that there is a set of articles called The Bare Essentials, published in Practical Neurology, and I wrote one about neuro-oncology about 10 years ago, and I read it recently. It's slightly out of date with some of the molecular fingerprints about the brain tumours, but otherwise it's a good read, and I would strongly recommend it. Thank you very much.